Medicine has transformed over the last 10 years. And if we're looking at where breast cancer was, particularly in 2005 versus where it is today, we've identified something like 40 drivers of the disease split across the luminals, the ER positive and the HER2s. So what most people are doing at the moment are detecting one or two aberrations on a particular platform like next generation sequencing and then matching a drug to that under a clinical trial. And they're usually doing this later in the disease on second or third relapse. So what we are doing, the Avera team, has three characteristics. Number one is that we're using several platforms. So we use a bare minimum of next generation sequencing and proteomics. We often use RNA-seq as well, and we're building in now a nanostring platform. The second thing that we try to do in every patient is close down all of the oncogenic drivers. So we're putting together combinations of drugs individually in each patient to try and kill the tumor by blocking all of the structural alterations. And then the third thing we're doing is treating very early in the disease course. That every patient stands a better chance of cure if treated early. Also, the genomic complexity is less at an early stage. So we feel that we can make the most impact by going early, using multi-platforms to try and dissect all of the genomic drivers, and then matching those with combinations of targeted therapies. I showed in the presentation, how the breast cancer has changed, how it's gone from, just a couple of drivers in 2006 into 40 drivers. I showed how those 40 drivers have potential matches in terms of therapy. I showed the same for lung cancer. And then we presented the results of, we've sequenced about 300, 400 patients, but we presented the results of our early ovarian and breast cancer data. So by using matched combinations against multi-platform analysis, in breast, on our fourth line therapy, we're achieving something like a 40% RECIST response rate. In ovarian cancer, we're doing even better. We have a 70% objective response rate in second and third line therapy. So with this approach, using just a next generation sequencing and using proteomics to discern the driving networks using that combination, we've put together combinations of targeted therapies, very often against PI3 kinase, mTOR, FGFR, etc. And at this moment in time, in our breast metastatic data, average fourth line of treatment, we are achieving a 45% RECIST rate. Our ovarian data are even better. Second and third line metastatic serous ovarian cancer, which is a very serious disease, progresses very rapidly. We have a 70% objective response rate, with 20% of those being complete responses. So it is the usual culprits. So there's a lot of PI3 kinase AKT, mTOR, phospho-S6, a lot of RAS-RAF, MEK-ERK, a lot of cell cycle control, which implies treatment with either palbociclib or Li-001. There is a lot of the upstream receptors, so FGFR, HER2, EGFR, depending upon the disease type, say ovarian cancer and basal breast cancer, a lot of DNA repair, but many of the common culprits. And then the other thing which we're seeing is what everyone refers to as the long tail in the curve. So we picked up a RET fusion in breast cancer, an HGF amplification, but these have to be taken very seriously because they're very often driving alterations in the disease. So we're putting together usually a combination of two of these, two of the targeted therapies. Very often it'll be one against the structural alteration, one against the driving mutation, and we're adding that on to state-of-the-art, ordinary, everyday therapy. At the moment, we've done all this under protocol but an early stage in the disease. So we've worked out a lot of the dosing that's required. We've also worked out some of the efficacy from using different patterns of drugs. Now we're about to enter into our 2 big neoadjuvant studies, where we take all 3 principles early: multi-platform, going early, combination therapies to tackle all the drivers.